Yes, good afternoon, everybody. Thank you very much for joining. Welcome you to the meeting.
Thank you. Thank you, sir. We have the Senior Product Manager here, Carol Tuomo.
Hello, everyone. Happy to be here.
Thank you. And the Business Manager, Mr. Tunji Oloyede. I don't know if he's here. All right, thank you. So to kick off this occasion, we'll be having our Executive Director of Operations give us the opening remarks, and then we would have the presentation. So I'll just go on to show us our agenda for today. Thank you again for joining us. Over to you, Pharm Kingsley.
Good afternoon, everybody. Particularly our guest speakers, Professor Fasanmade O.A and Pharmacist, Folasade Lawal, the CEO of Victory Drugs. We are happy to have you at this seminar, at this webinar rather. Now, I am on behalf of the Group Managing Director of Codex Group, Mr. Samuel Gunjimi. I want to welcome you all to this webinar. This webinar series is part of our contribution in Codex to the ever-expanding knowledge frontiers in the disease area. And I use the word carefully, ever-expanding, because sometimes when you go on TikTok or some of these social media, you get to hear of funny claims that get wide publicity. People believe in many of those things. So those of us in the core area, it's also important that we keep talking to ourselves and expanding knowledge, hearing from experts to know what is new, what is true, and what is not true. And then no other persons like the eminent prof to always talk to us and give us this information. As you are aware already, the topic to be discussed today is optimal metabolic control of diabetes. Now, the WHO, the World Health Organization, estimates that the prevalence of diabetes in Nigeria is around 4.3%. And this prevalence is largely attributed to lifestyle changes, amongst other things. And of course, because of that prevalence, that level of prevalence, it means that it carries its attendant burden on the healthcare system. We also know, because those of us who have been in this area, this area of treatment or business, can say that we've had numerous studies by experts. Like one of them, like our guest speaker today, have shown that impaired glucose tolerance is associated with increased risk for macrovascular disease. And also that reducing the risk of microvascular complication is achieved by improving HbA1c levels. So we know also that it is possible that by having self-monitoring devices of blood glucose is an essential component of diabetes care. And that is why at Codex, we offer a wide range of qualitative and affordable point of care devices for the diagnosis, screening, and monitoring of cardiometabolic related diseases. In Codex, our vision remains to be the leading African health tech company by 2030. And our mission, of course, is to improve the health of the nation by providing access to quality, innovative, and technology-enabled healthcare solutions for the prevention, early diagnosis, and management of diseases such as this, like we always say, our core area is metabolic diseases. So once again, I want to welcome you to this knowledge impacting series. I'm sure that as we listen to our guest speakers and ask questions, we are going to be richly blessed and enriched by the quality of the conversation. I believe that as many of you that have joined, doctors, nurses, pharmacists, and even our salespeople on the streets and on the road, meeting people every day, that the knowledge that we get from this webinar series will impact on the quality of advocacy that we're presenting in the various people that we're going to be encountering. Thank you and enjoy the program.
Thank you so much, Pharm Kingsley, for such an engaging introduction. It's got me really excited about this webinar, and I believe it's the same for so many of us on this call. At this junction, I would go ahead and introduce our first speaker who will be taking the presentation in the person of Professor Olufemi Fasanmade. Professor Olufemi Fasanmade is a professor of medicine and endocrinology at the College of Medicine, University of Lagos, and he has been a clinical researcher in the fields of endocrinology, diabetology, metabolism, and nutrition for about 2 decades. He obtained his MBBS degree from the University of Ibadan in 1987 and completed his residency training, bagging the fellowship of the West Africa College of Physicians in 1996 at the Lagos University Teaching Hospital. He has been involved in several researches and received several grants, including that for the world-renowned AAD-HEM study group, which has brought so much new knowledge in the area of diabetes susceptible genes in Africans and African Americans. The Diab Care Nigeria project, which characterized the poor level of diabetes control across several tertiary centers of health in Nigeria, and even the HIDE MPS program, amongst others. Is the immediate past president of the Endocrine and Metabolism Society of Nigeria and the immediate past chairman of the Nigerian chapter of the American Association of Clinical Endocrinologists. He has authored and co-authored 5 books and has 120 publications in peer-reviewed journals and more than 300 abstracts and posters presented locally and internationally. He has trained and supervised more than 30 fellows in medicine who are at the helm of affairs in many hospitals and universities within and outside the country. Ladies and gentlemen, healthcare professionals, it is my delight today, it is my pleasure to have such a renowned professor enlighten us on the optimal metabolic control of diabetes. You're welcome, sir.
Thank you very much for the flattering introduction. I will go straight to my presentation if you allow me to share my screen. It's a pleasure being on this platform with eminent people like Pharmacist Kingsley, Dele Akimbabola, and all the big boys and girls on the screen. I also am happy to be here with Pharmacist Folasade Lawal, one of the foremost pharmacists in community pharmacy services in Nigeria. So I will share my slides now, and please let me know if you can see them. Can everybody see my slides and hear my voice clearly?
Yes, sir.
Yes, we can.
Okay, so that is the title of my presentation, which is Optimal Metabolic Control of Diabetes Mellitus. I work in the Lagos University Teaching Hospital. I also work in the College of Medicine, University of Lagos, and I also am the Chief Clinical Coordinator of the NSIA Lute Cancer Center. So I will try to cover all of this within the 30 minutes allotted me, or 25 minutes. And these are the things that we'll touch on in the course of my presentation. I won't go deep into the drugs because Pharmacist Folasade Lawal will be doing that. But I will just be taking like a general overview, looking at optimal metabolic control. So when we talk about diabetes, we should remember that the hallmark of diabetes is hyperglycemia, but there are several processes that lead to this hyperglycemia taking place because the body normally does everything to maintain blood sugar within a certain range. But for you to develop diabetes, usually there are multiple problems, right from the incretins to the kidneys to lipid abnormalities, muscle utilization of glucose abnormalities, glucose disposal problems in the liver, satiety problems in the brain, and then the problem with the beta cells and the alpha cells in the pancreas. So all of these lead to hyperglycemia, which is usually chronic. To make a diagnosis of diabetes, usually you will require to test the blood because, as we said, hyperglycemia is the hallmark, and you can use either fasting or random or both of them with some specific criteria. You can also do a simpler test, which is the HbA1c, or you can do the traditional oral glucose tolerance test, in which case you have to be in the laboratory for about 3 hours. So what are the numbers that you use to make the diagnosis for diabetes? Usually, if you are doing fasting, you cannot just use one fasting blood sugar, but you require a fasting blood sugar that is persistently above 126. So it means if you do your blood sugar on Monday, it's 127, and you do your blood sugar on Wednesday, it's 128, that person has a confirmation of diabetes. On the other hand, you can do one fasting and 1 2-hour postprandial, in which case the fasting is greater than 126 and the 2-hour postprandial blood sugar is greater than 200 milligrams per dl. So those can be used in conjunction, or just 2 samples for 2 hours postprandial on separate days. So those are what we need to make the diagnosis for diabetes. If you want to use a simpler test, it's just the HbA1c, in which there is just one blood draw, and the HbA1c is greater than 6.5%. So these are how we make the diagnosis of diabetes. Why do we worry about diabetes? We worry about diabetes because high blood sugar on its own doesn't do too much, but it leads to several other problems. And this high blood sugar leads to the generation of free radicals. These free radicals, they damage vessels. There is glycosylation of proteins within the vascular endothelium and several other areas within the kidneys. So these lead to endothelial dysfunction. Hyperlipidemia also occurs, and because of all these changes and as they affect the blood vessels, blood pressure too tends to rise. So you find out that the complications that occur due to diabetes are due to multiple disorders of different parts of the metabolism and also the vasculature. When blood sugar continues to go up or remains up, it causes damage to almost all the tissues in the body. Every place where blood gets to has the potential of being damaged. And that includes the brain, the teeth, the heart, the eyes, the kidneys, vessels, nerves. All of them can be damaged by diabetes. So what do we do to make sure that all these things do not happen? So it means that we usually will try to prevent these complications. And to prevent these complications, we have to control the blood glucose. We have to control the lipids. We have to control the blood pressure. And to do all of these, you have to measure these parameters. Thereafter, you have to monitor them, because you may check the blood sugar and it's high today, but what is it tomorrow? So you must monitor them, and you monitor them regularly. For both blood pressure and blood sugars, you have to monitor these on a daily basis for most patients if you want them to have perfect control. And that means these patients need to have a point of care blood glucose meter, one that they can put in their bag, one that can be in their houses, so that they can check blood sugar at any time of the day that they so desire. In the past, when I was just in training, urine testing used to be a surrogate for blood sugars, but this is very inaccurate and comes with its own problems. So when you want to control the blood sugar, because once you've made a diagnosis of diabetes, then you must start the person on lifestyle. And after lifestyle, then you can now go to either monotherapy, dual therapy, or triple therapy. And the algorithm for this can be found online. There are several algorithms. There is ADA, there is AAC, There are so many of them. There is EASD, but they all say something very similar, which is you start with one group of drugs, you move to two groups of drugs if you are not getting to target, and finally you go to triple therapy or insulin. So this is the way that most people would treat diabetes. And to effect this metabolic control, usually you use different agents. As you can see on this slide, you either use drugs that will increase insulin secretion, or those that will reduce glucose secretion, or those that will reduce appetite, or those that will reduce glucose reabsorption, or those that will aid glucose uptake and utilization, those that will alleviate lipotoxicity, and those that cause reduction of hepatic glucose output. So there are different drugs which my co-presenter will cover. So type 2 diabetes is a major and independent risk factor for both micro and macrovascular complications, which we have mentioned before, the ones in the heart, kidneys, vessels, and so on. And the purpose of the algorithm, which I shared earlier, is to make sure that every patient is treated to target, and to also offer the patient a rational combination of the different treatment agents available. In my earlier days, there are just 3 groups of drugs to treat diabetes. It was metformin, sulfonylureas, and the third one was insulin. Those are just the 3 groups of drugs, but now we have more than 20, and that is why we have algorithms that are flourishing. And these algorithms are to address the patient needs, to improve the length of life and quality of life, because we all know that it's not how long you live, but the quality of life that you live that is more important. And for that reason, with all of these different drugs, we want to prevent complications and prevent comorbidities. And what are we trying to prevent? Again, without the fear of trying to bore you, they are still the same: blindness, kidney disease, neuropathy, amputation, cardiovascular disease, and the like. So all of these are the complications that we are trying to run away from and manage by making sure the patient has adequate diabetes control. For instance, 80% of diabetes succumb to cardiovascular complications. So more often than not, you find people that are seeing the endocrinologists are also seeing the cardiologists. About 40 years ago, road traffic accidents were the commonest cause of lower extremity amputation. But now 50 to 60% of amputations in almost any country in the world is due to diabetes. And these are due to either peripheral arterial disease, peripheral neuropathy, or a combination of both of them. And these 2 factors are driven by poor metabolic control. Diabetes affects every part of the family. It leads to miscarriages, stillbirths, and these are due to various reasons, ranging from fetal abnormalities, placental abnormalities, polyhydramnios, fetal macrosomia, and the like. So it is distressing to couples trying to raise a family. Diabetes also is one of the commonest causes of chronic kidney disease. So if you go to any dialysis center to see those who are receiving chronic dialysis, you find out that diabetes and hypertension are the major reasons. They take over 80%. And diabetes is one of the most common causes of end-stage renal disease. So people waiting for a kidney on a transplant list, majority of them will have either hypertension or diabetes, or a combination of both these NCDs. Another problem with diabetes is one that men fear, and that is erectile dysfunction. So if you have a patient who is very, very stubborn and recalcitrant, if he's a man, you can put the fear of God inside him by reminding him that if he does not control his diabetes, he's going to have power failure in his headquarters. So erectile dysfunction is seen in many people. We know that erectile dysfunction is common as you get older, but in diabetes, it comes much earlier. I have patients who are in their 20s and 30s who already cannot have an erection because of poorly managed diabetes. And for those that are able to even have an erection, quite a number of them have dry runs because the ejaculation goes in the reverse direction into the bladder. So they will have infertility and they'll be wondering where is this semen going into. People with diabetes also are often afflicted with visual impairment, which, if not properly treated, lead on to blindness. And these visual impairments are due to either retinopathy, maculopathy, cataracts, glaucoma, or infections of the eye, or combination of all of these things, which end result leads to blindness. When you want to control diabetes, when we are talking about metabolic control or diabetes control, usually there are three things we are looking at. Two of them which are strictly metabolic, and the third one which is an offshoot. We are looking at A1C, blood pressure, and cholesterol. That is the ABC of diabetes care. So when you are seeing your patients, make sure that you address each of these during each visit the patient has. And for us to be able to do that, what is usually advocated is the decision cycle for patient-centered glycemic management, which means you put the patient in the center and then you start going from one thing to the other. For instance, assessing the person's characteristics, considering the factors that might impact the choice of treatment, sharing decision-making with your patient and creating a management plan, and going on to implement this management plan. And then you continue to monitor the patient's well-being, lifestyle, and other things. And then you review and agree on the management plan. So it is a cycle in which you are making decisions together with the patient concerning his own or her own care. How do we assess metabolic control? I will say it again. The most important one is to check the blood glucose, but there are other things that you can check, which include the cholesterol levels, E&U, and then glycosylated hemoglobin. How do you monitor glycemic control? In the olden days, endocrinologists had a terrible way of assessing glycemic control. If they had a clinic with 10 patients, they had to taste the urine of each of these patients to know how sweet it was. Thank God I wasn't born at that time. Thereafter, it moved to urine testing. And then in the early part of my career, we started having blood glucose testing. Either we are using wet chemistry or dry chemistry, which means using the lab or using your glucose meter. And with that, you're able to monitor the fasting and the 12 postprandial. Patient is able to make decisions based on these results. And you can fairly well predict what the HbA1c will be when you are in charge of monitoring your blood sugars. Other things that can be measured for some people who HbA1c is not suitable for instance, those who have sickle cell disease, you can measure fructosamine, glycosylated albumin, or the nails. In the era of urine testing, I told you it wasn't a very pleasant era because the doctor would taste each person's urine and say your control is good or is poor. But it was very, very crude and unpleasant and not objective. Then the urine testing came to the fore with different urine testing tablets initially and then strips much later. And then finally, we got to the stage where started being able to test the blood glucose using different meters. So for blood glucose testing, because if you are monitoring something, you have to monitor them in a smart manner. And what do we mean by smart manner? Well, when you look at SMART goals, it talks about specific, measurable, achievable, relevant, and time-bound. But I've modified that a little bit, because if you are testing blood glucose, make sure that it's not only specific, it is safe. Make sure that it is well measurable. Some glucose machines will not measure under various conditions of maybe temperature or humidity. And then make sure that once you check your blood sugar, it is accurate. Not that you check on one machine, it's 200, you check on the next machine, it's 400. And then you must have them being relevant, reliable, reproducible, and then you want your results immediately. I know a few patients who still will tell me that, doctor, when I go to the lab, I will check my blood sugar. That doesn't have good time consciousness, because you now have to go out of all your way to go and do this test. For a patient to be well controlled, you need to take into cognizance the glucose triad. And what does that mean? For you to say a patient has all-round glycemic control, not only should the fasting glucose be good, the 2-hour postprandial should be good, and the HbA1c should be good. Some patients, they just want to check fasting and they run with that. But if you check fasting, you're going to miss hyperglycemia that takes place post meals or later in the day. So please let us encourage our clients to test randomly at other times apart from fasting alone. To optimize diabetes control, we need to educate, health education, specific diabetes education, monitoring of glycemic control, good nutrition. You need to empower the patient. Let the patient know what decision is right based on his blood sugar. And we need to have a multidisciplinary team care approach. Like on this call, we have an endocrinologist, we have a pharmacist, and we have other specialists. So when we talk about optimal metabolic control, what blood sugar are we talking about? The ADA and ACE are relatively generous because they say the fasting should be between 90 to 130. But in my own personal practice, I tighten the knots a little bit, and I tell my patients to do either 70 to 110 or 80 to 120. For 2-hour postprandial, most of the guidelines will tell you 100 to about 180. I tell my patients that having very good control is very important, so I don't allow them to get to 180. Then the HbA1c should be between 6.5 to 7.5. And the lower figure would be for those who are very sharp, they don't have any cognitive problems, and they are very well motivated. While those that we allow 7.5% to be their normal are less motivated people, especially elderly people with type 2 diabetes or type 1 diabetes. Then we also want the lipids to be normal. We want the electrolytes, urea creatinine, to also be normal. And the uric acid should also be normal. So what are the drugs that we use to prevent these complications? We have oral and injectable glucose-lowering agents. We have statins, we have ARBs, ACIs, and other hypertensives. And then sometimes you use supplements or vitamins. For lipid control, to have optimal lipid control, we use the mnemonic 54321, which means your total cholesterol should be less than 5, non-HDL cholesterol should be less than 4, LDL less than 3, triglycerides less than 2, and HDL, sorry, that's an error, HDL greater than 1. So these are what constitutes an optimal lipid profile. We've mentioned before that to optimize glycemic control or metabolic control, you should use different means. And one of them is diet, in which you refer your patient to the dietitian, exercise, drugs, self-monitoring of blood glucose, which is very, very, very important, very, very key, regular clinic visits, remote access to the healthcare provider. Quite a number of people don't want to release their numbers to patients, but a few of us do. And then remote access through such means, so that if your patient is even in his village, he can send you a message and you can guide him or correct him. And then further monitoring using the HbA1c or the CGM. Treatment must be patient-centered. Patient-centered, which means always remember that the patient is the most important member of the team. Do not prescribe some drugs without discussing with the patient. He or she must be empowered. You educate him so that he can answer your questions. And they must have access to their blood sugar readings. So there should be democratization of glycemic monitoring. And they should be trained to be part of their own management team. So you can ask them, what do you think about this? Can we add this? Should we reduce this? Let them join so that you can own the process. In summary, diabetes is a very, very serious condition. It leads to diverse complications, which I've listed earlier in the presentation. And for this reason, we should manage diabetes very, very well. We cannot manage without monitoring metabolic parameters. That should be without. The patients need to be at the center of their own management, because they are the ones that have diabetes 24/7. You only have the patient for a few minutes, a month, or a week. These patients need to engage in monitoring their metabolic parameters, including blood glucose. And they need to be able to do this very, very effectively. These are other papers that you can read to shed more light on this and to increase your knowledge. Thank you very much.
Thank you so much, Professor Fasanmade, for such an enlightening session. Particularly for me, seeing the numbers that I need to monitor to make sure that I can confidently say that I have optimal control of my metabolic health was quite enlightening for me. And knowing that at the center of whatever treatment I would receive in ensuring I have optimal control of my blood glucose level, knowing that I'm at the center of it when the multidisciplinary team is managing me, for me, is a very enlightening one. And I think it's a message that our sales team would try to imbibe with our healthcare practitioners. Thank you so much, sir, for such an enlightening session. I would now go on to bring on board to present to us Folasade Lawal. Thank you, sir. So Pharmacist Folasade Lawal is the MD and CEO of Victory Drugs in Lagos, Nigeria, a pharmacy that she founded in 1989. Awesome. She's a fellow of the Pharmaceutical Society of Nigeria, a Commonwealth Professional Fellow, and a member of the American College of Chest Physicians and American Diabetes Association. She has been involved in numerous health awareness campaigns on non-communicable diseases like hypertension and diabetes. She's a strong advocate of the rational use of medicines. She chaired the Drug Information Center of the Association of Community Pharmacists of Nigeria for 9 years, and she's currently advisor to the ACPN-DIC. She has collaborated with and effectively delivered various local and international level projects with several international organizations, institutions, and pharmaceutical companies since 2005. She's very innovative in the practical solutions she has brought to the effective practice of community pharmacy, patient involvement. In fact, when Professor Fasanmade was giving his lecture, I was just excited knowing that Folasade was going to be presenting next. And and she's very innovative in ensuring patient care. Pharmacist Olufunke Lawal is a seasoned academic, a well-published author in peer-reviewed journals. Without much ado, it is my delight to welcome to this webinar Pharmacist Folasade Lawal to educate us on the optimal metabolic control of diabetes from the perspective of a pharmacist. Thank you, ma'am. You're welcome on board. You can go ahead and share your screen.
Good afternoon, everyone, distinguished colleagues, and every other healthcare professional in here. Thank you, colleagues, for the opportunity to share a few experiences with us. I was given 15 minutes to do my slides, so I'll be as brief and fast as possible. And thank you, Professor Fasanmade, for doing a thorough job. In fact, everything has been sorted out from Prof's lectures, very wonderful lectures he gave us. So I just rushed through my slides, and my outline is as follows: a little introduction. We look at our peculiarities as community pharmacists, our roles in diabetes care, roles in the care of diabetes patients, and then we take a few real-world patient experiences and conclude. So, like Prof has traced to us, sorry, something is talking. Diabetes is a major public health concern, and as we know, hypoglycemia influences development of long-term complications from diabetes. So, that is why diabetes control is very key to that management. We just have to get it right there if we don't want our patients to develop comorbidities, or if we want to delay the development as much as possible. So we need to maintain near normal blood glucose levels and blood pressure, because if we don't, we can have considerable reduction. I mean, if we do, we'll be able to have considerable reduction in the risk of them developing particularly microvascular complications. And then diabetes patients need the support of well-trained and enthusiastic healthcare professionals to get optimal control of their diabetes. As we know, diabetes patients generally, they have a lot of burden for their diabetes, and it's a life journey with, like Prof said, it affects every part of the body. So when somebody has that kind of a condition, they have a lot of emotional instability. There's so much wrong, and we just need to come up there to strongly give them all the support that they need to pull through. So why are we looking at community pharmacists? Because research has it that the community pharmacists are considered the most accessible healthcare professionals. It's easier for the patients to get through to us. We are within them in the community. They don't need to book the prior appointments, and then because also it's in the community pharmacy setting that we're able to pick up more of those who are yet to be diagnosed, because both those who are ill and those who are not ill, or perhaps let me say a third group, those who are apparently well coming to the community pharmacy, not necessarily for just drugs. So it's a very accessible place for us to prevent and treat. So community pharmacists provide services like medication optimization, point of care, unit dose dispensing, lifestyle modification, non-pharmacological intervention, injections and vaccination services. Like Prof also said, diabetes care, like most or almost all healthcare matters, are multidisciplinary. We just need one another. For diabetes particularly, the patient is at the center of the care. And then the rest of us are just there to help that patient manage himself appropriately. So we drive, we mobilize, but the patient is the major driver of his or her health. So the patient is at the center. And evidence suggests that it's best managed through a multidisciplinary team. Of course, the pharmacist is part of that team. So our roles primarily are in prevention in terms of primary prevention, secondary and tertiary. And I'll explain primary prevention. We're looking for patients who are at risk of diabetes or pre-diabetes. And then we want to get them at that stage. We don't want them to develop, particularly type 2 diabetes. We don't want them to develop it. So we want to get at them before they get into that stage. And like I said, the community pharmacy is a good area to get that done. Then secondary, we want to help in preventing or delaying development of complications for those who are already diabetic, but yet to be diagnosed. Those who are already diabetic, many of them, we see them in the community pharmacy a number of times. They're just going about, they don't even know that they are diabetic. And then those who are diabetic but are already at risk of developing complications as well. Then there's a tertiary level of prevention where we also come in. And there we want to prevent consequences of complications. But eventually they're already there. So this slide is looking at criteria for testing for diabetes or pre-diabetes in asymptomatic adults. This is something that we can make use of in our community pharmacies. And this should be considered in patients who are overweight or obese. The following risk factors should be put into consideration. They are first degree relative with diabetes, if they have high risk ethnicity, history of cardiovascular disease, if they are hypertensive, if they have HDL levels that are too low, or let me just put that as dyslipidemia, if they have a history of PCOS, if there is physical inactivity. For patients who are generally physically inactive, it's also nice that we look out for diabetes in them. Then other clinical conditions which are also associated with insulin resistance, like severe obesity. Then we should also look at patients who are pre-diabetic, and there are so many of them. We come across them in the pharmacy from time to time. Patients with a history of gestational diabetes also. Then other patients, their testing should begin at the age of 35. That means that any patient from 35 and above that walks in to your pharmacy and has not had a test for diabetes in probably a year or so is a candidate to be invited for testing. This is very key because we see a lot of them come into the pharmacy. Sometimes they blame these things on malaria. They're looking for malaria drugs to treat malaria. I might just chip that in and get them screened. I don't know what this slide is not moving. So this slide also talks about categories of increased risk for pre-diabetes. And then we also have, sorry, something is blocking my slides. So I'll show you. This gives some values that we need to look out for in diagnosis of diabetes. Professor Fasanmade has dealt a lot on this, so I will just skip through it. Now, the pharmacist's role in the care of diabetes patients. Now we're looking at, we focus more on care of patients that are yet to be diagnosed, care of diabetes generally. So we're looking out for patients that are still yet to be identified with diabetes, but they are probably at risk or already there without anybody knowing. Now we want to look at our roles in the care of patients that have diabetes. And this slide says that we contribute holistically to diabetes management. Number one, we educate our patients about their condition, their medication, lifestyle modifications. But medication is very key, especially as pharmacists, and we see a lot of them. I recall a patient that was on Vidagliptin and Treviamate at the same time. Inadvertently, was overdosing on Vidagliptin. So we need a lot of medication. We need to help them to look out for drug therapy problems that they might not be aware of. Then we serve as resources to other healthcare providers and payers to assure safe, appropriate, cost-effective medication use. We work with the patients and other healthcare professionals to optimize treatment outcomes. Now, this table gives us an algorithm on management of type 2 diabetes patients. And the first thing we do is an assessment. We do medical history, physical examination, and laboratory evaluation. Prof has talked a lot about them. Then there's a treatment plan. We work with the doctor. We refer them when we suspect or we have reasons to believe that they have diabetes. Then there's a treatment plan from the doctor. Sometimes the patients, if we're able to relate with the doctor, like we do many times, the doctor will tell us what goals they have set in terms of their sugar levels, what they want their blood sugar levels to be. Like Prof was saying that he would rather put his patients as a little lower than the maximum. So we work with that plan to help the patient to achieve what has been set. And Prof has also stressed a lot that this management is individualized. So we have individualized treatment targets, individualized treatment plan, which includes diet, exercise, anti-diabetic agents, prevention or treatment of complications, as the case may be, and a lot of patient education. So it's a team. There is no how we will not need the services of the dietitian. And in the pharmacy, we can collaborate with dietitians. We can refer our patients to see these dietitians. Then from time to time, we review the treatment plan. And when we are doing that, we want to consider, is there the need to adjust the plan? Is there the need to adjust education? Is there the need for referral? The patient is not hitting target despite all what we know to do and we have done. Then the next thing might be to refer the patients. Then we also have administration of the treatments. The medications have to be right. And this is so many competitors. We have a lot of people, Dr. Goga or whatever, advertising all sorts of remedies. So your patient is taking some concoction. Sometimes they bring this concoction, they don't even know the names, they don't know what's in it. And that might be interfering with the medication itself or hastening comorbidities developing. So we need to look at that as well. And then we must give appropriate instructions for the use of these medications and then educate the patient. This my patient that was using Vidagliptin and Treviamate. It was at the doctor prescribed Treviamate, and he didn't know that he was to stop the Vidagliptin and switch over to Treviamate. So one very important thing that we must do is monitoring. We must monitor compliance with treatment. Prof has given us a clue, especially when they are men. to let them know the risk of erectile dysfunction if they're not adhering to therapy. For women, I don't know. I think we should also, women love beauty a lot. We can let them know that diabetes affects every organ, including their skin. So that may also help with women. So we need to help them to monitor the treatment plan, treatment outcomes. What do we want to achieve? Are there adverse effects? We should help them to monitor their RAN. Then monitor patients' understanding and continuing education needs. And that's why we have to be sure that they got whatever we have said to them, ask for feedback, and all of that. So now we want to look at components of pharmacist intervention evaluated in type 2 diabetes. This is a research that was done, and this table was called out. Sorry, my slides are misbehaving. This study was done by A and co, and they looked at the effectiveness and acceptability of pharmacy-based intervention in type 2 diabetes. So from this table, they grouped them into the stage, intervention, and components, and they found that in treatment plan, the intervention that community pharmacists were able to do is medication review, and that's a specialty. We do a lot of that. So we intervene based on the outcome. When we identify drug therapy problems, the ones we can resolve, we resolve. Like this was easy to resolve because the patient was the one that put the add-on. But if the doctor needed to be informed, then we would work with the prescriber to resolve whatever medication therapy problems we find out. Then patient education through consultation. We need to educate the patients about disease progress, goal setting, lifestyle, psychosocial support, self-monitor of blood glucose, which is very key. Then monitoring, so we need to look at the monitoring treatment outcomes. That is what this research did. They looked at monitoring treatment outcomes, and they found out that community pharmacists did review of blood glucose results, physical examination, that their blood pressure, weight, feet, skin. Like I said, every part of the body is affected. They looked at their HbA1c measurements, and then they monitored compliance through adherence questionnaire. And when we monitor compliance through adherence, we want to help them to overcome whatever obstacle is between them and their adherence. It could be that the brand they are using is so high they cannot afford it, and there may be better alternative, less expensive alternative. So sometimes they might need to switch them to generics, especially if the branded was prescribed, then we might need to involve their doctor to say they're not able to afford this. I had this patient that he was always on 3 months appointment. 2 weeks his appointment was when he would buy his medications and use, and then he will go to the clinic and he will be certified. I mean, he will be told that his parameters were okay and they were not okay. So we had to write his doctor to let the doctor know what the problem was and get less expensive medications for him. So other things that were done were partnership with other healthcare professionals, liaising with the prescribing doctors, referring the patient for education at higher levels than we can do, referring to specialists or referring for medical advice as the case may be. So this research brings out many of the things that we can do for our patients as community pharmacists. In terms of economic value of our intervention, there are limited studies, and this publication too talks a little bit about the economic value of the community pharmacist intervention in diabetes care. Now let's do a little on HbA1c and diabetes control, because HbA1c is a very key intervention in diabetes care. And from my experience in community pharmacy practice, many patients are not even aware of. I've come across a number of diabetes patients that didn't even know what HbA1c is. And we have seen quite a number of patients that all they were doing was monitoring their fasting blood sugar. And like Prof said, it's a triad, it's a triangle. The three components must just be there. The fasting blood sugar must be there, HbA1c must be there, the postprandial sugar must be. All of those three must be considered in the patient's care. And that is obvious. When we look at some of the cases that I put here, we'll find out where they come in. Now, the intervention of the pharmacist goes beyond sales of drugs. We know that, and we're already doing a lot of that. It's our business to ensure that the patient achieves glycemic control using the prescribed treatment. That is, whatever treatment the doctor has prescribed, we need to see through to be sure that that patient is achieving control. If it's not achieving control, then something is wrong with what we are doing. So for diabetes patients, recommend you advise a regular HbA1c test. It's one of the ways you can foster better medication therapy outcomes for our patients. American Diabetes Association recommended HbA1c as a possible substitute to MBBS in the diagnosis of diabetes. I saw that in one of the journals that I reviewed. HbA1c is not only a useful biomarker of long-term glycemic control, but also a good predictor of long-term comorbidities like coronary artery disease and stroke, because it gives us an overview of what is happening in the last 3 months. Sometimes the patient does a hit and run thing, or there are some other conditions that make you see a fasting blood sugar that might be normal, but the HbA1c would reveal what is happening. In the same way, too, that HbA1c might be all right, but there might be times that this patient has hypoglycemia or hyper in between, and there are ways that we can help our patients to identify that. One of the instruments that we use in my pharmacy is this 360-degree view, where the patient takes 3 consecutive days readings, and it does before breakfast, after breakfast, before lunch, after lunch, before dinner, after dinner, and last night at night consecutively for 3 days. And then we plot a graph and we look at where the issues might be. Then we're talking about HbA1c and diabetes control. A study by Sophie and co found out that there was an association between HbA1c and dyslipidemia. So HbA1c and dyslipidemia have an association. Characteristics of traditional and non-traditional markers of hyperglycemia. Here we are looking at the fasting blood sugar and HbA1c. I will skip this too because Prof has handled this in this lecture, and I have only 15 minutes. Now let's look at what is in vogue right now. Thank God that was not born when Prof, in the era that Prof talked about, where people would be testing urine to know what was happening to the patient. We've all come past that era, and God has brought us to a much better era where we have witnessed remarkable advancements because of technology. And we are now looking at integration of monitoring devices that have revolutionized how patients and we as healthcare professionals track glucose levels, dietary habits, and physical activity. Now, these tools empower patients to take control of their health and aid our work as pharmacists to guide them through this process. So it's important that we embrace this as much as possible and be abreast of it and on top of it. Now let's look at integrating HbA1c and lipid profile testing in patients' care. I got an acronym for that, PEP. That means that PDP stands for point of care devices for the test. We must have point of care devices to every patient especially when it comes to FWACP and lipid profile, because they're not things that they want to do every day. So they're not willing to stock these meters, and it's not even necessarily economical for them to. So they want to come to the healthcare professional. At the time we are saying that at that point of care, we want to help them to know what is happening as the need arises. So it's important that we have the point of care devices. We need to educate the patient on the significance of these tests. And that is why they will buy into it. And then we must personalize the care plans that address both the glycemic and the lipid profile. So that's my PEP. It's not the PEP of HIV now. I'll take 2 real-world patient examples. I'm trying to rush because of my time. This 45-year-old Mrs. XYZ complained of a little sore on her toe. She thought that sore came about because she had pedicure. So she blamed it on the pedicure. But why she sought help was that it seemed not to be healing, and she had been with it for a few weeks. So she came to the pharmacy, and then when we clapped, we found out that she was hypertensive. She'd been on calcium channel blockers and diuretics for quite a while. And because, according to her, most of the time she was able to manage her blood pressure, she felt she was having good control. She hardly saw a doctor. In the 5 years that, the past 5 years, she had not really seen the need to see a doctor, because every time she measured her blood pressure, she said anytime it went high, it was either because she needs a medication or something upset her, and after a while it would go back to normal. So she thought she was okay actually. So we decided to help out to do it was difficult to do a fasting blood sugar random for her because she had not eaten for very many hours. She said she was on a fast. So we're not sure how reliable the fasting blood sugar was, or whatever blood sugar. We didn't know what to call it at that point in time. So we decided, we offered her HbA1c, and she agreed to do HbA1c. And then it was 11%, and she had not been diagnosed with diabetes before then. We also offered her to check her lipids, and she had this lipidemia, so we had to refer her to follow. This table also teaches us about initial evaluation of high glycated hemoglobin in non-pregnant adults. Now let's go to the second case. This 7-year-old Mr. Raf worked as a security guard. So he was a low-incomer, and he presented with this leg ulcer that had a terrible odor, even though it seemed it had covered up. It just had a scald on it, but it had foul odor. And we talked with him. We found out that he knew he was diabetic, was on drugs for very many years, according to him. But when he could no longer afford, he now resorted to bitter leaf. And then for the sore, he said he was powdering metronidazole and chloramphenicol. He mixed them together to apply on the sore. So we had to pick him up from there. Interestingly, when we did this random blood sugar test, it was 90 milligrams per dl. And initially, I was wondering in my head, what could be going on here? Then, of course, he could not afford HbA1c. But I just had to get that one for him. So I offered him HbA1c free, and he agreed to do it. And then we got 9.5%. If I recall, we had to refer this patient to Professor Fasanmade, and he gladly helped out. And the patient ended up on admission at Lutz for about a month. He came back later to thank us for that intervention, because according to him, he would just have died off, or his leg would have gotten to the stage of amputation. The sore was well managed and it's healed. So that is the power of collaboration. That is the power of prompt intervention from the pharmacist. This table also talks about how we can monitor our patients with DM. Sorry, I believe that the slides will be made available because of time I'm rushing through. So I will not go into the nitty-gritty of the table, but the important thing is that there are interventions, there is the frequency of those interventions and comments. For example, we need to take history and physical, take history and do physical examination. It also talks about the frequency of those examinations, like the BMI should be at every visit, the weights in particular. Once we've established a BMI, and the height is constant, smoking cessation if the person is a smoker, BP should be at every visit. We should look, there should be dilated eye examination, which will be done by the ophthalmologist. Comprehensive foot examination should be done annually. We can do a little in the pharmacy. If we don't see anything to worry about, if we are trained to do that for another 6 months. In my pharmacy, we do 6 months. And sometimes when we find issues, interestingly, about to call Dr. Fasanmade, Professor Fasanmade too, about his patient that had a very tiny injury and he acted properly about it. So those examinations, we can do a little bit of it in the pharmacy. Then dental examination should be annual. Then laboratory studies need to be done. Lipid profile, A1C, basic metabolites. Prof has talked extensively on them. A1C is every 3 months until we get very stable reports. Then it can be once in 6 months. I mean, when we get normal values for, well, then it's important, especially now that we are talking about community pharmacies and vaccinations. We need to know the vaccines that will protect our patients. And pneumococcal vaccine is one. Influenza is to be done annually. They should take their COVID. We know that COVID in patients that have diabetes, the outcome can be very terrible. Then hepatitis B, because they're exposed to regular piercing, and then other routine vaccinations for adults with diabetes according to age-related recommendations or probable conditions. We've had a case where the patient was on dialysis. The patient came for erythropoietin, and we found out that that patient had not been protected against hepatitis. So we just wrote a letter to the doctor managing to say, this patient who will benefit from hepatitis B vaccine and the dose, and the doctor was very happy to say, please go ahead and give. So let me quickly conclude by saying that as community pharmacists, we have strategically positioned to help prevent type 2 diabetes, which is preventable, or at least delay the onset maximally, and then contribute professionally to optimal metabolic control of diabetes. Thank you. References for that reading.
Thank you so much, Ma. I mean, I just developed a whole new appreciation for pharmacists. I mean, I wouldn't be looking at my community. I know my community pharmacist is very valuable, but right now I feel like they are one of the biggest MVPs of healthcare. Thank you so much, Ma. That was very enlightening. For as many of us have, as many of our participants, many of our attendees that have questions, you can please put your questions in the Q&A. There's a Q&A button on the call. You can put your questions there. You can also put it in the chat box. We'll be taking your questions just after the product presentation. We know that time is fast spent, so we wouldn't be asking too many questions for our panelist discussion. But I just have 2 questions particularly, one for Professor Fasanmade and one for Pharmacist Lawal. For Professor Fasanmade, I'm curious to know, you spoke about having a multidisciplinary team managing individuals living with diabetes. And, you know, during our presentation, Pharm Lawal mentioned quite a few real-life scenarios where she had to call you in to intervene with a patient. I don't know if that is the norm presently. So I'm wondering, how can healthcare practitioners at primary and secondary level work together to ensure comprehensive and coordinated diabetes care, sir?
Thank you very much for your question. When we say multidisciplinary team, there are different sizes of such a team. For instance, if you're in a very small place, it could just be the doctor and the nurse, or it could be doctor, nurse, dietitian, pharmacist, cardiologist, nephrologist, ophthalmologist, physiotherapist. So it ranges in size, and it also depends on what the patient presents with. A patient that doesn't have any complication and is very, very well controlled, it may just be the endocrinologist and the dietitian, or the endocrinologist can just start the treatment and send them back to the person that referred, whether it's a primary care physician or a community physician, and say, well, I've seen your patient is doing perfectly well, let him continue with you. I'll be seeing in the next 6 months to 1 year. So collaboration makes work easier so that everybody is able to share the burden. So that's what we mean when we are talking about a multidisciplinary team.
Thank you, sir. Further to that, I'm wondering, do you have many cases where you have people that maybe have gotten advanced in the disease, where you think that maybe if at the community level or at the primary care level, or maybe when the general practitioner saw them, if maybe they had been tested, say their HbA1c had been tested or their lipid profile level had been tested, do you think that would have caused us to have, or that would cause us to have less people having, more of those complications since the disease has advanced?
Yes, in quite a number of people, they look at diabetes in a very, very narrow view. Some people, for instance, they just check their fasting blood sugar once a week and they feel they are fine. In the area of sugar, fasting is different from random, and all of them are important. Others, they check both fasting, random, but they never check kidney function. They never check lipid profile. Again, that's a very, very myopic view of management of diabetes. You could have perfect blood sugars and your cholesterol is sky high. That patient will suffer from a myocardial infarction. I'll be wondering, why did he have that? Or will suffer a stroke. So you must look at all the parameters. Blood sugars must be checked, lipid profile must be checked, renal function must be checked, ECGs, echoes should be done. So you must look at the patient in totality. Diabetes is not just a sugar disease, it's a disease that affects all organs, and the sugar is not the only metabolic thing that goes wrong with diabetes. Thank you.
So much, sir. Thank you so much, sir. Okay, so my next question now will be for Lawal. Thank you so much for the real life scenarios that you talked about. For me, they were quite relatable. So, in talking about it, you mentioned how sometimes you had to offer free. There was a particular case where you had to offer free HbA1c test, and it turned out that that patient really needed it. So I'm wondering, what are the challenges and opportunities in integrating HbA1c and lipid profile testing into diabetes management for your clients? What are the challenges? How can we? I'm sure that there are many pharmacists on this call that would very much love to run this test for their patients, and there are some challenges they are thinking of, and they are thinking of how to overcome them. What are the possible bottlenecks, and how can we, from the pharmacist point of view, overcome them? How can we, from the general practitioner point of view, overcome them? And what are the opportunities that lie in taking advantage of point of care testing for this parameter?
Is a question for me or for Pharmacist Lawal?
For Pharmacist Lawal. Then when she's done, I would love to hear from your view, particularly for the general practitioners. So I want her to speak to the pharmacist's point of view first. Thank you, sir.
There are many challenges, but I think all surmountable. There might be the challenge of space within the pharmacy, because that's something that is very confidential. So there has to be a corner at least where that test can be done or where those tests can be done. Then another big challenge is the cost, because sometimes you have to buy the machine and then buy the strips. And sometimes when you have not started, you don't even know how much is going to come out of this. Before you invest the money in the machine, you don't know how many tests you will do before you will recover the money that you have spent. So I think these are major challenges. The others are probably poor education on the part of the patients, poor knowledge on the part of the patients, medical knowledge now, not necessarily academic. And like I said, they are quite surmountable. I recall the first time that we invested in lipid, we started with a lipid profile, of the big ones. And then the company said if we could buy up to, I think, 200 strips, we would get the machine free. And I didn't know what the journey would be like. The strips are living things because they can die. So they have expiry dates. So what I did was to say, okay, let me pay you for 200 strips and collect the machine. But I'm not collecting 200 strips from you at a go. I will collect piecemeal. So we struck a balance that worked. So I was picking up the strips piecemeal. Even when their price went high, they had no choice but to give me the strips. When that batch expired, they had no choice but to still give me other strips. So I didn't lose out. The only thing was that, well, too, they were like a bank. The money was with them. So they were turning it over. So it was a win-win at the end of the day. And we found out that patients were happy to have that as part of their point of care. And there are many interesting ways that you can make patients buy into it. Even patients that necessarily, appear very well. We do what we call heart disease risk assessment. Very engaging one in a very interesting way. It calculates different figures and it puts value to, if you don't know what your values are, it gives you a high score. So by the time we are done and you see yourself with a high score, you're like, how did you get here? Then we tell you, because you don't know what your lipid profile is. Okay, can I know? You can know, but at a cost. And a number of them would want to know, because if it's too high too, that means that they could even have been worse than they were. So there are so many interesting ways to surmount these challenges. Which of them are very not covered? I think that has covered.
Thank you so much. I don't know if I'm speaking. I don't know if I'm speaking on behalf of all pharmacists here to say that you've pinpointed some major worries and concerns, even some objections that we get on the field, that our sales team get on the field. I don't have the money, I don't have this. And knowing that, you've clicked and you've actually, taken advantage of surmounting this challenge, and you can testify that your patients are the happier for it. I think that's a very good testimony from you. So I'll go on now to Professor Fasanmade to see what challenges, some GPs, some challenges, some endocrinologists. I know some endocrinologists that have side labs, and some of them have actually bought some of these point of care devices, while some have still not, keyed into it. So what challenges are or opportunities lying, purchasing these analyzers, purchasing these cartridges, or carrying out this test? Thank you, sir.
Yes, the challenges for having point of care devices usually is one of patient volume, which Pharmacist Lawal has alluded to, because if you are not primarily an endocrinologist that every day you sit down and see 20 people with diabetes, even blood glucose strips, you will find out that they might expire or they may get damp and then they may not work. But if you're in a busy clinic like my clinic, whether it's in Lut or outside, then you won't have that type of problem. But for a general practitioner who sees 10 malaria, 3 live typhoid, 2 pneumonia, one sore throat, and only one hypertension and maybe one diabetes in a day, you might not be able to invest in such, except if you can use the method that Pharmacist Lawal mentioned, collecting just a few, and then when you exhaust them, to collect more. And that is if the company is willing to provide such support. On the other hand, what a GP can do is to arrange like a community screening, provided that community is ready to pay for the costs of checking blood sugars and lipid profiles at the community level. So those are the challenges. But if you have a situation whereby packs of these disposables, like the strips, are few and are not liable to quickly get damp or exposed or expire quickly, I'm sure it's a valuable and veritable tool for such a GP, if he has the clientele that can afford it.
So much, sir. I really do appreciate. Right now, we are going to take the product presentation from Codex Pharma to be taken by my colleague Ayodele Akimbobola. While we are doing this, I want to encourage us to please type our questions. You can use the question and answer box. You can use the chat section to actually type in your question, and we'll take it immediately after the product presentation, which shouldn't exceed 5 minutes. Ayodele, over to you.
Okay, thank you very much, Olade. First of all, Fasanmade, thank you very much for your time, and from Lawal, I think it has really been a learning curve for every one of us that has been on the call. I sincerely appreciate your presence, and I'll just speak to one or two things before I move into my presentation. Basically, I'm already sharing my screen. So I've been able to take out some key learnings from this presentation. I've been able to, one, to notice that there should be a target for all patients. And from what Professor Fasanmade has said, even looking at the ADA guidelines and the ACE guideline, his patients are having a target, and he stood out for me. And also the holistic view of saying that it's not just the sugar, which everybody keeps talking about. The multidisciplinary approach of looking at things in different directions, a practical example that Pharm Lawal also mentioned of how they're able to help the patient out. But the question is, assuming Pharm Lawal did not even go through the basic steps she has highlighted, I'm sure they won't be able to check the A1C for these patients, and those patients might have been left out there. The patient might eventually lose his or her life because of that. So I think self-monitoring also, in terms of things we need to do, was clearly stated as part of the things we would need. And I'll be talking about, I'll be doing a product presentation basically. So I just let me touch on one or two things that I've actually learned from the presentation. Either we like it or not, there'll be gaps to right treatments. And from everything we've said, there are actually gaps. And if there are no gaps, we don't even have this kind of series to talk about one or two things. I was reading the news that the federal government is begging the resident doctors to come back. So it means that maybe in Luz, Professor Fasanmade will be the only one, and some free consultants seeing all the diabetic patients. And he still has other things to do. And I can imagine what that would turn out to be. And even the advent of mass exodus of physicians, pharmacists, lab scientists, and healthcare workers generally, you see that there's a lot of gap in the manpower that we have there. So definitely there's need for a lot of interventions that we need to have around to ensure that our patients achieve their treatment targets. Even in talking about the diagnosis, that we are from the practical example of what we saw of a patient that was referred by Pharm Lawal to Professor Fasanmade, we saw that assuming what they were using, so let me hide this part so that I can see me clearly. So assuming that when they wanted to check the guns for that patient, it got an inaccurate result and the reading was showing 5% instead of, I think, about 11% that was mentioned, we would see that it would have caused a lot of things. And I'm so sure if the time of the result took maybe some days for her to achieve. Maybe she was referred to the lab and she got there. She saw that there were queues or some things there and she couldn't even access that care. She would have gone back, gone to her house and think that whatever she's doing, she's actually right. So there are dilemmas to diagnosis basically. And sometimes, like we said, not affordable to patients and the use of the test and the devices. So we would see that there are dilemmas basically. And from Codex, we are trying to see how we can help with this, how to ensure that we solve this problem, we bridge the gap that is already in existence. So we have some quality and affordable, innovative point of care devices. During the presentation of Professor Fasanmade, it clearly mentioned that for the blood pressure check for diabetic patients, it should be daily. The fasting and the random blood sugars are things that a patient shouldn't say, I'm checking once in a week, I'm fine. The HbA1c is also very, very important in assessing control and management, from also what Folasade actually shared, Lawal shared. The lipid checks are essential too. Professor Fasanmade clearly mentioned that the lipids, glucose is not the only metabolite that is affected in diabetes. Other things are involved, protein, lipids, and every other thing is involved in diabetes. So we can't just say that we are focusing on the fasting or the random blood sugar alone and leaving other things out there. So from Codex, we actually have some innovative point of care devices that can help you address this concern. What Professor Fasanmade and Lawal has done is for us to teach us how to fish, what they've done excellently well in their field. And from Codex, we're not giving you what you need to use in fishing, which involves some of the diagnostic tools, the point of care devices. For our fine test blood glucose meter, which is what we have, it is used to test for the fasting and the random blood sugar. It is easy to use, gives results in 9 seconds. It has fish strips inside, is affordable and available everywhere. There's 2 years warranty, and it can also auto-calculate results, which helps patients to even keep their reading and help them make informed decisions. From what we've learned, patients are the center, and a patient must be informed on what he or she is having to ensure that they achieve the targets that we want at the end of the day. We also have our blood pressure monitor, which, from what we've learned, patients to check their blood pressure daily. And you have our Codex BP monitor that is user-friendly also, is affordable. It has IntelliSense technology, which makes it very, very accurate. It has a large pulse size. It can detect irregular heartbeats. It has both voice function and backlight function, which makes an individual to actually have an understanding of what his or her reading is talking about. So it helps you to cry out and meet maybe your pharmacist that is nearer to you or your doctor for appropriate referral and recommendation. And it can be used by 2 people because it has 2 different memory sets, and each memory can take about 90 readings. So for that, if you have a patient that wants to check his or her BP monitor, his or her blood pressure, you can go for the Codex BP monitor. And those that want to check their fasting and random blood sugar, you can go for our fine test blood glucose monitor. Comparing our Codex BP monitor with other BP monitors, we have things that are comparable with them to tell you that our BP monitor is affordable and is also effective. Going back to the dilemma of HbA1c that I mentioned from what we said earlier on, for a good patient that we talked about that was saved by the intervention from Professor Fasanmade and Lawal, we'd see that inaccurate results still comes out, long waiting period for results, not being affordable to patients and that thing, then ease of use. But one thing I would just like to talk about is that Lawal mentioned the fact that space and some other things might be a challenge. But when we look at what we are offering for Clover, which is our HbA1c analyzer, we see that one, we can get our results in 5 minutes. It is very accurate. Because per test is less than 3,000 naira, it doesn't require a technical, like an extra technical know-how to ensure that your patient gets his or her HbA1c done. We know that there are different there are different ways of measuring the HbA1c, which is the glycated hemoglobin. We have the immunochemistry method. We have some spectrophotometric method. We have some enzymatic method of measuring HbA1c. But for Clover, one good thing that stands out is that it uses the what we call the bromate affinity. So the boronate affinity, and the boronate affinity speaks to one good thing. Considering other spectrophotometric methods, boronate activity is greatly is not as impacted as other means of checking HbA1c when it comes to the different variants of hemoglobin in the blood. What I mean by this is that when we are looking at glycated hemoglobin, we are looking for the hemoglobin that is found in the blood for about 3 months. But there are other things that are found there. We have other variants. Maybe someone that is, for example, someone that is AC, that has other hemoglobin. So there are other variants in the blood that actually alters the result of HbA1c. But for boronate affinity method, it's much more specific and it is not affected largely by this variation in hemoglobin. So to a large extent, Clover is very, very accurate. This boronate affinity makes it very, very accurate. You get your results in 5 minutes. It doesn't require highly skilled person. It's a closed system. It's very accurate and it is portable. So when you're thinking of space, when you're thinking of turnaround time, when you're thinking of accuracy, Clover is there for you. To check for the lipid profile and the lipids we've talked about, it's not something that is far-fetched. There was a webinar I was in there and the doctor said in their center, they don't usually do lipid check because by the time they ask them to go to lab and come back, it might take 1 or 2 days and patients might not even come back to get their results. And I'm like, when you have an analyzer that can give your results in 2 minutes of your LDL, HDL, triglycerides, then you know that you can give your patients something that is holistic. And it's not just stopping there, because for our Lipid Pro, it is fast and reliable. You can get your triglycerides, your total cholesterol, your high density lipoprotein on the Lipid Pro analyzer. And you can actually calculate your LDL from it. And the calculation is there. That is total cholesterol minus HDL minus total glyceride divided by 5. So this would actually help us make informed decisions. And for Codex, we are not stopping here to say, once you diagnose this patient, we also want you to have something to treat them. And that's why our focus as a cardiometabolic company is very, very strong. And we don't just say that, yes, we are giving you the right thing to treat people, but we also have medications to help them out. So for patients too, for our drug baskets, for example, for people with that you need to help them with their statins, we actually have our code atorvastatin, which is a lipid agent. I won't spend much time on the cholesterol pathway, but it actually works on the HMG-CoA pathway. And by doing that, it helps to actually reduce the LDL, improve the HDL, the total glycerides in the body. There are different schools of thought that how good is atorvastatin. So there's a trial that was done for 7 different statins, and they had about 51,000 patients that were used in that study. And it was found out that atorvastatin, well, to a large extent, might not be the statin alone that can actually reduce the LDL to the barest minimum, but it's among the top 3, top 2. And one good thing is that it improves the HDL, which is something it has over rosuvastatin that is popularly known. So comparing the ability to also reduce the LDL, it's very comparable to rosuvastatin. And looking at even total cholesterol, atorvastatin had a better profile compared to rosuvastatin. And taking it further, in terms of toxicity profile, once you are increasing the dose for atorvastatin and rosuvastatin, you see that in terms of side effect profile, atorvastatin has a better side effect profile as compared to rosuvastatin. So for us, like I mentioned earlier on, we are not just stopping on just the statins. We have other cardiometabolic drugs that patients can use. For metformin, we have our extended release 1,500 milligrams. This helps in compliance. It helps to reduce pill burden for your patients. And above all, is very, very effective. We have our amlodipine that can be used for a calcium channel blocker that can be used for diabetic patients. Professor Fasanmade quietly mentioned the use of ACIs and ARBs in managing diabetic patients. So we also have our Ramipril, which is an ACI. We have our Codiuretic. And for us in Codex, we see ourselves as a partner to our healthcare providers. Thank you very much.
So much. We are your partners in providing quality, accessible, and affordable healthcare. Thank you, Ayodele, for that. We've been having some questions pouring, although our panelists have done us the justice of answering some of these questions. We still believe that we should mention these questions to everyone on the call, so that for some of us that have the same question on our hearts or on our minds, we can also benefit from the answers of our panelists. And just after these questions are exhausted, we would be having our head of sales give us the closing remarks, signaling the end of this webinar, and then we'll communicate the slides, how to get access to the slides or the information on the slides in the follow-up email after the webinar. So someone here says, thank you for the wonderful presentation. I think this question would be to Folasade, although I believe that Professor Fasanmade may also be able to speak to it in case it's coming from a doctor. So she says, thank you for the wonderful presentation. My question is for patients who cannot afford HbA1c because of the cost implications. Is there any other way? I think she means, is there any other way around it? So Folasade, although you already answered the question, I'd love you to still communicate it orally so that many people can benefit from the answers.
Okay, thank you once more. Well, there are many ways around this actually. It depends on the patient. The important thing is to let the patient understand the importance of this test as that affects his or her diabetes. Then if it's your patient that is close to you, you might decide to let the patient pay on installments, because the patient is not going to need another test until 3 months' time. So you can spread the maybe 5,000, 6,000, 7,000 over a month or two, pay you in installments. You might decide to give a discount. You might be magnanimous enough to just write it off, depending on who that patient is to you. So those are the options that I have.
Very much, ma. Professor Fasanmade, do you have anything, any addition to this?
For a patient who can't afford HbA1c, because most places, if you go into the lab, you will be spending between 7,000 to 10,000. And if it's point of care in community pharmacies or other places, I'm not too sure whether it will be so cheap that everybody can afford it. For those who can't afford to do HbA1c, having your blood sugars within range, fasting within target, postprandial within target, even if you are checking 3 or 4 times a week, will give you a good HbA1c. Thank you.
Thank you very much, sir. This just reminds me of one time I visited a pharmacy, and then on the pharmacy wall, there was something about the short pleasure of buying cheap and buying cheap drugs that are not working is very short-lived compared to the long-term effects of paying for quality drugs. So I don't know if that applies to this scenario, but knowing that this test is once in 3 months, and just like Lawal talked about, educating our patients and letting them see how that having optimal metabolic control by monitoring their HbA1c level would serve them in the long run than in the short term. So I think that idea of having them pay in installments might also work. And then, Professor Fasanmade is saying that they can test 3 or 4 times a day. That means that we need to encourage our clients, we need to encourage our patients to actually have their own blood glucose monitoring device. And thankfully, we have the FineTest glucometer as an affordable option and a user-friendly option for many of our patients. Thank you very much for your answers, sir and ma. Somebody asked if the lecture slides can be shared. Yes, they would be. You would communicate how to get access to the lecture slides. Okay, we have a question. I said, your machines, are they being offered together as a combo? Okay, are you asking if we offer the Clover A1C analyzer and the lipid profile analyzer together as a combination? Yes, we can look around that. We can look around that. Just send a message to us, send us an email after this call. We'll put our phone number, our customer care phone number in the chat section. Now you can call us, you can speak with your representative on how we can work together with you to enable you have these devices in your facility. Well done for the presentations. How much is the blood pressure monitor? Our sales representative would reach out to you on the cost of all of our devices for as many of us as are interested in purchasing these devices. Where can we get the drugs and devices at an affordable rate? The beautiful thing about Codex is that we have a very wonderful assets in the form of our sales team. Our sales team are very wonderful. We have sales representative in all 37 states of the country, and so that means that wherever you are, we have a sales representative that can cater to your need, and we have a logistic. We partner with a logistic company to get our devices delivered to you, to get our products delivered to you at no cost, at no charge to you. And so you do not have to worry about your location and getting our products. And they are very affordable. You only need to speak with our representative to know what costs they come at for both the drugs and the devices. Okay, there's a comment here that says there's a need for physical presentation, especially for health practitioners in Northwest and Northeastern Nigeria. Thank you very much, Mr. Musa, for this observation. I'm sure that the head of sales has taken that into account, and the sales representatives in the Northeast and the Northwest have taken account of this. So we'll be working together with you, working together with our sales representative to get this done. Okay, someone here says, thank you for the wonderful presentations. Prof, okay, so this is to Professor Fasanmade. If someone's fasting blood sugar, PPBG and random blood sugar, okay, postprandial blood sugar and random blood sugar are consistently normal, but impaired HbA1c level, does that mean the person can still be diabetic? Okay, so Professor Fasanmade, I think that question is for you.
Usually, if you're having that type of situation where fasting is perfect, every other thing is perfect, random at any time is perfect, and the HbA1c is still high, then there is likely to be an error with the HbA1c machine, or there are some other things in the person's blood, maybe the type of his hemoglobin.
All right, thank you very much, sir. I believe that answers the question. We'll take our last question on this call that says, thank you for the wonderful presentation. I really enjoyed it. Thank you for the feedback. Says, but my question is, in a place whereby you cannot afford the glucometer machine to buy, in order for you to be checking often, is native herbs okay? Professor Fasanmade.
It is not okay at all.
At all. All right. Thank you very much, sir, for your response. Okay. I believe we've answered all this. I want to see if we have any other question we've not answered. Okay, so our contact is in the chat section. Thank you very much, Professor Fasanmade. Thank you, Lawal. We'll get the closing remarks from the head of sales now, and then we'll close the webinar. Head of sales, Mr. Eni. Mr. Eni on the call.
Thank you very, very much. Thank you. Yes, I'm on the call. Thank you. I want to firstly say thank you to Professor Fasanmade and to Pharm Lawal. I definitely took something out of that. I thought it was really useful, very, very simple but informative systems. And I think, obviously, to all the people who've attended, I hope you really found it very useful. For me, on the clinical exchange side and the sharing of best practice, I've taken that multifaceted control of the complications of the metabolic conditions of diabetes is something that we must all take serious, looking at renal control, looking at eye control, looking at the lipids, looking at all the end organ damage targets that we can really do something about controlling. And obviously, we at Codex are very proud to say that this partnership that we have with the healthcare professionals at large, all the doctors, the nurses, the scientists, the pharmacists, the associated healthcare network. The idea basically is for us to bring health technologies that can really help. So it augments what we heard from the doctors and the pharmacists and all the contributors today. What we're trying to do basically is to improve the health of the nation. We're really grateful for you taking your time to join the meeting. To the speakers, really appreciate it again. And obviously to the Pharm Lawal, we really like that whole idea of what it can do in the community. We're taking some of the points that we mentioned on, and we will do something about it to come back. But please reach out to your local representative, to the people online. If you have any information about Codex that you want, check our website. But we just want you to know that we are here to partner with anybody that wants to improve the health of the nation, for their patients, for their service, for themselves, to really help people alleviate some of these real complications of diabetes that really makes the cost of management become prohibitive. Because if we can actually get on top of it with these numbers that we know are very useful, then we can really bring some good, long-lasting solutions to what is happening. So we really want to thank you, and obviously to my colleagues who worked tirelessly to put this meeting together. We're very, very grateful for the webinar. And I'm sure that all the people who've joined will find something very useful out of this that they can take to improve the health of their patients. Really grateful. Grateful for everybody, and thank you for giving us your time. Thank you. Over to you, Lolade.
All right. Thank you. Thank you so much, sir. On this note, we want to say thank you to everyone that was in attendance. Thank you, Professor Fasanmade. Thank you, Pharm Lawal. Thank you for joining us. See you next time. See you hopefully next time. So we bring the webinar to a close. Bye.
Thank you, everybody. Bye.